Well, welcome to the fourth session today. And it is a pleasure to introduce our speaker, Arijit Patra, Senior Principal Scientist in the UCB UK and Honorary Senior Lecturer in the University of Glasgow. Dr. Patra is the Principal Scientist at UCB, and he imaging for the University of Oxford. He was Rhodes Scholar. Prior to that, he completed a dual degree in mechanical engineering from the Indian Institute of Technology in Kharagpur. He has also been associated with AstraZeneca, Cell, Microsoft Research and CSIR-South Africa at various points in his career, and has been actively involved in the AI for SG, A for Social Good community, and was an invited expert to the UK-India track dialogues on technology, security and diplomacy. He is author of several publications in machine learning and different areas, particularly with application in medical imaging and health areas, with publication in the most important avenue like NeurIPS, ICML, MICCAI, and so on, and several journals. And really, he is an excellent research and reputed research, and it really is a pleasure, an honor for us to receive him. That will now this week we start with some applied area, and this is the first talk in the area of health. Today, his talk and then the talk next day we have some talk in different areas, and this one is in the responsible AI in healthcare, fundamental aspect associated to the topic that we have discussed along last week. Thank you very much, please.
Okay, thank you, Paco. Hello, everyone. So it's a bit late in the afternoon, and I'm also quite sleepy, and everyone else probably is. So I'll try to make it, kind of like as appealing as possible. And as you see today, we will be talking about responsible AI for healthcare and pharmaceutical drug development. And we will try and touch upon different technical, policy, and societal interventions and imperatives around this theme. So one thing to note is that, because obviously there will be a lot of overlap with some of the other presentations you have already had, because different aspects of responsible AI has been covered elsewhere. So there might be some overlaps, in terms of the discussions that I'll be having. And so particularly for a lot of the technical stuff that I have on the slides, I'll just skim through and I'll focus more essentially on the big picture. And also I'll kind of talk about my experiences as a scientist doing drug discovery and drug safety and designing clinical trials, and also my views on what assurance and responsibility might look like going forward. So I want to make it as interactive as possible, so please ask questions in between and just stop, etc. There are a lot of slides here, so we'll probably want to not cover everything in equal depth, but if you want something to be covered more than I do, then please come back to the end and then we can see what we can do. So yes, I start with this timeline, and this is a timeline that I found on the internet that does capture the sentiment aspect of responsible AI very well. And what is worth noting is that, when you look at some of these early efforts in 2014 or so, at the time, there was a very specific context in which responsible AI first became mainstream. And this context was not exactly around deepfakes or anything like that. A very big turning point was essentially in 2009, 2010, when the whole Cambridge Analytica scandal broke out. This whole idea that, you could use a lot of very specific kinds of electoral data and use it to kind of do targeted campaigns. So this essentially the whole idea of responsibility in a digital system, that discussion till then was very nascent, was very much coded into other kinds of priorities, say for example like preventing harm, preventing access to children, etc. But the first time it became a mainstream discussion in its own right was in that turning point where people realized that you could essentially use recommender systems to do targeted campaigns for and manipulate political results because of that. So a lot of the discussion kind of then also was augmented with a lot of other innovations that happened. For example, with the whole kind of the Cambrian explosion of deep learning architectures, the emergence of deepfakes and advanced GANs that allowed you to essentially create a lot of very kind of manipulated imagery and so on. And once again, a lot of very defining elections in the US and in a lot of other countries, in India included, which kind of saw very large scale use of some of these systems. So, and that is how a lot of the galvanization happened with regards to like questions around like to what extent technology can be used responsibly. And this kind of like led to other kinds of like analysis on how there might be bias encoded in the algorithms and in the nature of data itself, leading to some seminal papers like gender shades, and then a lot of work by Timnit Gebru and Joy Boulamani and others, and then kind of like the concept of model curves, etc., emerging. And then over the years, this discussion has kind of snowballed due to kind of like the emergence of more powerful algorithms, a more foundational kind of like a design architecture, and better kind of like an amalgamation of compute and data. So where does healthcare fit in? At an aspirational level, there has always been this idea that somehow we might be able to cure all disease and revolutionize medicine's discovery and enhance human flourishing and whatnot using technologies like artificial intelligence, and you see versions of this even today. But the defining feature of this point in time, in the second decade or the third decade of the 21st century, is that for the first time we are at a convergence of three curves at a kind of like an inflection point where some of these promises can actually be realized. You are at the kind of very interesting convergence of like capability, data, and kind of like a regulatory pressure and like the imperative to compress discovery timelines in this market. So today the vision, the aspirational vision has gone from like mere targeting of like subparts of the healthcare stack to kind of like a more end-to-end and a holistic vision, and thereby complicating the responsibility and the accountability landscape along with that. So if you were to look at some of the the development pipeline itself, like there is kind of like a whole different set of components that come together to make it a homogeneous whole, and obviously a lot of the concerns essentially stem kind of like across the whole value chain in different parts of it. Now, one of the related aspects here is that like for a lot of us who kind of have done kind of our research activities in this space, like we have looked in the question of like building assistive systems in healthcare or building AI augmented systems for healthcare delivery, something that we very often appreciate or something that we very often talk about in a nutshell is like the whole idea that to what extent are we going long on promise and short on actually the delivery of systems, and to what extent are we considering the perils and pitfalls of some of these systems that we build. So there is kind of like this whole promise around using artificial intelligence systems as assistive technologies for reading scans, of analyzing reports, of handling large scale data. But there is also this pressing reality of unexplainable effects or untractable kind of issues like hallucinations, and like more systems level issues like bias, and kind of like this whole idea that technology evolves way faster than regulation can actually catch up. And then as more and more of these systems kind of get into multinational deployments, the question of intermediary responsibility comes up repeatedly. Like who is accountable for what, who is accountable for what part of the stack, and who is accountable for what failures. And therefore, it is important to appreciate, and this is a message you will obviously have heard repeatedly in this summer school, is that responsible AI is not a constraint on innovation. It's a means, it's a track that can actually allow you to enable innovation responsibly at a breakneck speed. It's kind of like the rails on which the train and the engine of innovation can actually go at a speed that can actually benefit society rather than kind of entrench existing issues. So before we go any further, I mean, it's important because we are talking a lot about generative and agentic in the context of the summary school. In the context of healthcare, it is important to understand in a very briefly, is that when I talk about generative, I'm talking about essentially the idea that it can propose and not just classify. So essentially classic generative machine learning, sampling from a data distribution and then coming up with kind of like a reconstruction of the input space maybe. When I say agentic, I'm talking about essentially a kind of like essentially an interaction based kind of environment where multiple systems can actually interact in the wild with emergent behavior or with and without like policies set around. And when I'm talking about things like this idea that it has shifted from the AI as a tool to AI as a collaborator, this also very well means that this could very well be collaborators where the ecosystem is entirely of agents or a mix of agents and humans, and that kind of complicates the responsibility landscape a little bit as well. So as such, when you talk about AI applications in healthcare, obviously this pie is burgeoning significantly from sort of like things like, say, for example, understanding target biology in diseases to end of life and palliative care. But roughly in the ambit of this presentation, some of the verticals that I would mainly touch upon would be essentially be diagnostic healthcare. Then I will touch upon a bit around drug discovery, and then I will touch upon the clinical trials aspect of it. Once again, lots to talk about, very little time, so I will just skim through all of that. If you want a more specific discussion on certain things like clinical trials, find me after the event. I mean, I can talk about any of these themes a lot. I mean, I have a lot of emotions and feelings about some of these topics. So now, you know, when you look at a lot of the stacks that I talk about, I mean, why is responsibility such an imperative? I mean, it's quite simple. At the end of the day, we are talking about human systems. We are talking about human flourishing. We're talking about improving human life. You cannot improve human life, you know, without having sufficient safeguards to simply not make things worse. In a nutshell, that is very classically the responsibility imperative that we need to understand as technologists first and foremost in the era of like building like some of these systems for healthcare. So with this, I think it's important that I talk about a few preliminaries and very preliminary concepts that kind of underlie some of the core concerns. By no means is this exhaustive, but some of the more prominent ones. So the first, and you would obviously have a lot of other speakers who talk about these, I mean, some of these issues and some of the, you know, the discussion and some of the more interaction that you face on a daily basis here. First of them, let's talk about bias. So before I proceed further, I want to kind of like ask a question to the audience. When you hear the word bias, what is the first thing that comes to your mind? Anyone?
Discrimination.
Discrimination. Anybody else? When I say the word bias, what is the first thing that comes to your mind?
Unbalanced data.
Unbalanced data, okay, more technical. And anyone else?
Unsensible data.
Unsensible data, so basically data that does not have a place in that setting. But you are talking about more on the technical machine learning side, but on a societal side, on your daily interactions with the outer world, when you hear the word bias, what does it mean?
Different place.
So, okay, disparate treatment. Okay. So we have kind of like a bit of a idea here. Even in this crowd, we have kind of like a, you know, very atavistic understanding of a concept like bias. I mean, which can take so many different forms. You know, disparate treatment, discrimination, and more technical aspects like, you know, unbalanced data, which is a manifestation of it, and kind of like, you know, having kind of like imbalance therein. So in a sense, we are really talking about essentially a deep human kind of a feeling of unfairness when you're talking about bias. I mean, at the end of the day, we are talking about something that is kind of like a more human concept before AI or even otherwise. But what happens is when you talk about a technical system which has to be replicated in scale, it is important to talk about bias in a more, you know, kind of like a guarded and in a mathematical sense, and talk about it in a very specific kind of a definition as it might apply to healthcare, which has proven to be an insanely difficult challenge to do, and still yet we don't have a good definition of that is all encompassing as it regards AI for healthcare. That said, what we can certainly talk about are like the few defining characteristics of bias in healthcare data. The first thing to note is that bias is not entirely random. You know, one of the main common kind of like discussions that you hear or used to hear in a lot of technical medical imaging conferences like MICCAI, etc., was that somehow bias is kind of like, you know, just happens randomly because of some issues with augmentation, etc. But no, at a meta level, bias is not entirely random. It is essentially a systemic presence. It's a reflection of essentially human history itself. It's a reflection of historic inequities, historic injustices, and historic lack of accountability. And, you know, like when you talk about things like who received care, who received, you know, what kind of like an enrollment we have in clinical trials, and what kind of a societal understanding we have when you talk about the idea of healthcare delivery or care delivery. And I can give a very personal example here from my current profession. So I work at UCB. We do a lot of work on, say, for example, rare disease understanding and so on and so forth. And therefore, we also work a lot on diseases like that are essentially deal a lot with pain, like things like rheumatoid arthritis, psoriatic arthritis, and so on and so forth. And one of the things that I've realized over the years is that when you talk about, say, for example, clinical trials in some of these kind of conditions, in a lot of societies, women who suffer from conditions like, you know, sort of rheumatoid arthritis, osteoporosis, or psoriatic arthritis, etc., in a lot of societies, due to thousands and thousands of years of social conditioning, when you ask to rate people on, you know, their pain, joint pain and things like that, essentially symptoms that are subjectively reported, in a lot of societies, women actually report or underreport pain significantly more than men. And therefore, if I have to have kind of like a drug that has to go into a clinical trial that is meant to alleviate this symptom, the very fact that there is a coded bias in that kind of a reported experience effectively means that any AI system that I use, and I have to get predictive on the, you know, sort of the aspect of like, say, clinical trial success for particular populations, will carry forward a bias that would essentially eventually there is a possibility that it will cause my medication to be less effective against that gender in that particular group. So this is kind of like the, sort of the provenance of bias that gets carried forward. So this is how it kind of gets into like daily practice. That is how it kind of gets into like the more, day-to-day practice if not corrected at the source. And your algorithm would be biased, and there would not be a very long time audit that will eventually debias it. So this is where actually this is kind of like a very live example of why kind of like bias as a systemic issue can end up influencing algorithmic decision and every downstream process associated. And we have kind of like more kind of like diagnosed or like reported kind of issues, like for example the whole issue around kind of like a lot of the dermatology classifiers being kind of like effective only on certain kinds of skin tones. And also like this, the more famous example here was reported essentially for a lot of like CCTV camera analysis, etc. But we have seen similar effects for a lot of cases where there are applications like skin cancer diagnosis and so on and so forth. So at the end of the day, a lot of the bias essentially is a reflection of some of the things that you guys are talking about. It is essentially a reflection of discrimination in thought, which leads to underrepresentation. It is essentially a representation of lack of enough data. It's essentially a representation of disparate treatment, which kind of historically meant that a lot of certain communities would not receive care. And it also means on a mathematical scale, a lot of the definitions that we use to kind of understand from a data distribution, at what point is my data biased, at what point is my bias relevant to a particular application, and what might be the interventions to correct the bias. Now, of course, like in a lot of the technical presentations that you might have seen about this topic, a lot of the conversations for correcting bias would have taken the form of things like data augmentation, of using techniques for actually lower dimensional data like SMOTE, etc. And at higher dimensional data, this is one of those cases where there is some promise for generative AI algorithms to actually correct for sort of biased data, but this itself has to be a deeply human intervention. This is one of those things where you have to use human in the loop to actually unearth bias and actually talk about how some of these things can actually be curated for. So this is kind of like one of those things which you simply cannot do away with human oversight. So this is one preliminary. And I have this pulse oximetry example here. This is a very good example that this is not just an AI problem. Even your standard hardware interventions can actually carry coded bias due to underrepresentation. During COVID, we had this issue that a lot of pulse oximeters were not sensitive to people with darker skin. And that was not an AI problem. That was a simple societal design problem. So it is essentially a bias by design problem that had to be addressed at the human level. So next preliminary, fairness. Once again, something that would be discussed a lot in the summary school, obviously. And I think like this graphic here is quite revealing on how we have kind of come to terms with some of these things. Like till about 2014 or so, none of these things were very much in the Overton window, and all of a sudden, like, we kind of have like a more of a explosion of discussions around this. And while you do have some of these, conversations on fairness at a more kind of at the classification level and more at the level of things like, say, for example, sentencing algorithms, or things like, for example, public benefits and public infrastructure access and so on and so forth. Healthcare is a bit of a different problem when it comes to fairness. And this has deep implications for the solutions we design for algorithmic fairness. While in a more non-healthcare setting, you have kind of like a fair body of research that has come about, to address things like demographic parity, counterfactual fairness, and so on and so forth. With healthcare, the problem is a bit, interesting, let me put it that way. For example, when you talk about things like, say, for example, if you were to ask a question at a group level that why did certain groups have, all else being equal, a particular kind of like a predictive power for certain algorithms, let's say for things like, predicting success rates in school examinations and so on and so forth, and a kind of like a correlation to things like postcodes and so on and so forth, very famous papers, some of the foundational examples there. But in a healthcare setting, it is very much possible that for reasons that are not always very well known, that certain communities are more prone to certain conditions than others. Certain demographies and certain kind of like regions are more prone to certain ailments than others. And crucially, we do know for a fact that due to the complexity of the human genome and a lot of like genetic evolution markers, certain medications do not work or have particular kinds of side effect than others. And a lot of that issue, the last issue that I talked about, is actually once again due to the long history of particular practices of injustice, etc., that might have come about in certain communities, etc. An example of the latter would be, say, for example, in India, in southern India, there are certain communities for whom a lot of very standard anesthetic agents that are acetylcholine based do not work in a hospital setting because they have developed a recessive mutation as a community due to a few thousand years of consanguineous marriages. And today, if I am a drug discovery kind of like a outfit making the next generation of anesthetics, and I were to kind of use, let's say, even data from within that province in India, most of my algorithms would simply predict a standard line of anesthetics that will not take into this aspect into consideration. In a way, it will kind of like have kind of like, fail to take into the exclusion mechanisms into consideration, then that would end up causing kind of like a harm. In a pure machine learning sense, you might say from a fairness perspective, pure mathematical fairness perspective, that the algorithm did all right in the sense that it just took into account demographic parity. But this was one example where the demographic, discrimination would have been crucial for the eventual outcome to be, kind of like healthcare relevant. So this is a very kind of like a very slippery slope kind of a domain as healthcare, where fairness can have very different ramifications at different times. So this is something, as a community, there hasn't been a lot of kind of like work that is fully satisfactory in terms of how do you reconcile both these objectives of maintaining group fairness or kind of fairness in the care delivery mechanism, but at the same time being cognizant of the fact that the diversity of the human race means that purely at the diagnostic level, there might be sensitivity towards certain protected attributes like race or caste or gender and so on and so forth. And this is the clinical reality we must confront with when building fair AI for healthcare. So there are a lot of ideas around it, that what might be the technical interventions in this space. I mean, I've heard of ideas and have tried working on it a bit. For example, using maybe a well-trained LLM, a contextually and culturally sensitive LLM as a judge for when to apply demographic parity and when not to, when to bring in what kind of a fairness ecosystem, etc. But at the end of the day, the upshot is that you cannot have a one-size-fits-all systems designed for fairness when it applies to high-risk healthcare applications. And this is the message I want everyone here to keep in mind when they're building fairness for healthcare. What will be the technical interventions? A lot of ideas, the field is wide open. And this will be one of the most defining research agendas for the next decade or so. What does fairness mean for healthcare? Okay, the next preliminary. Explainability. Okay, once again, hot topic. Everyone talks about explainability. Not a lot of people agree on what explainability should eventually mean. A lot of different schools of thought again, like ranging from like model level explainability to like post hoc methods to things like understanding the feature space better, and to understand like to what extent we are willing to have explainability in sacrificing of accuracy. So there is also this other kind of school of thought that is increasingly emerging here around mechanistic interpretability, which kind of talks about kind of going into a neural circuit level to understand sort of like failure modes, etc. And so the core issue here is that, particularly for healthcare, when you talk about explainability, is that there has been a lot of evidence, particularly for connectionist systems like deep networks, that high accuracies do not necessarily mean that the model is looking at what it should. And it is very much possible to have that classic scenario. I think this was a interesting presentation from 2017 or 18, where an algorithm learned to qualify horses by learning how grass looks like, and therefore horses on the beach would not get classified as horses. So this is a situation that happens very commonly in healthcare. I have seen a lot of situations where there are very highly reported accurate algorithms for fetal ultrasound, which entirely overfit on the acoustic fan windows kind of exogenous region, so in the black part outside, and give a very good kind of like an accurate result on essentially things like kind of like fetal biometry and so on and so forth. And also we have seen a lot of this in radiology, for example. Very often like there is an overfitting on sort of text on an X-ray, and kind of that being used to kind of give a diagnosis. And because no one bothered to do an explainability audit, the algorithm ended up getting like a lot of attention and a lot of like getting very well funded as well in some cases, despite having kind of like results that were not of a provenance that was clinically meaningful. So I think a core question as regards explainability in healthcare, first of all, comes from the fact that whether a model is looking at features that can be remotely identified as clinically relevant, or are there spurious correlations forming. So, and there is kind of like a bit of a argument here to be made here that when you talk about whether a model is looking at what it should or not, we are really defining it from the human point of view, from the human clinician point of view, that a model should look at certain things in a, let's say, in an X-ray image. What if the model is able to discover like features that are imperceptible to the human eye or the clinician eye, and that is maybe clinically meaningful? So essentially, What if the model essentially discovers what DeepMind calls the move 37s in a X-ray image, let's say, and that eventually ends up getting discovered as diagnostically meaningful. So there is that push and pull there, like to what extent you kind of think of something as a spurious correlation, unless it is blatantly obvious, like it overfitting on the essentially the text on the in an image and so on, and to what extent does it have to be actually human clinical relevant, like to what extent it has to kind of comply with sort of like actual clinical judgment and actual clinical protocols that have been developed for a non-AI world. Obviously, from a regulatory standpoint in most countries, the second aspect is absolutely crucial for SAMD deployments. For example, the FDA software as a medical device still places a premium on the provenance being kind of like from a human clinician judgment point of view. But it is very much possible that things that are identified might contain information that are just not perceptible to the human eye, that may eventually be found to be relevant clinically. But that is too high a risk margin, so something to keep in mind. That is something that we have not reconciled yet fully, that what explainability means in this context. So I guess the idea is that it's always better to have human in the loop, a human clinician in the loop, and there will be no replacement of radiologists by AI anytime soon. So if you were to look at, say, for example, everything that I talked about, and if you were to look at kind of like a scenario for discrimination and inequality as a result of these preliminaries kind of being violated, like this figure is a bit dated and there are more, different kinds of things that happen now. You can go from all kinds of things like sort of discrimination in terms of unequal access to treatment. Remember the example that I gave about pain? That's different kind of communities kind of report pain differently due to cultural encoding. This also can very well mean that if a chatbot or an AI system were to be used to actually administer like pain relief medication, let's say for arthritis, kind of patients, etc., and if these are kind of like medicines that are sort of like controlled, like let's say steroidal substances and so on and so forth, it is very possible that an algorithm would kind of like repeatedly, due to the bias against some of these specific groups that underreport pain, it would kind of make that same prescription error, despite actually those patients otherwise being very good candidates based on other symptomatic history to receive those medications. So this is how bias actually can propagate deep into diagnostic systems, and therefore there is a need to kind of like have kind of like a human oversight that is also debiased in addition to algorithms that are debiased. So this is just one example of the kind of the magnified harm that can happen in a care setting because of the preliminaries that I talked about. So moving on. Hot topic again, agentic healthcare AI, and let's talk about a bit about safety. Okay, before I go into this slide, when I say the word safety, what comes to your mind? Anyone?
Margin before failure.
Margin before failure, good. That's a very factor of safety definition. As a mechanical engineer, I'm proud. Yeah. Yes. Anyone else? What does safety mean to you? Robustness, okay. So once again, robustness is tied to the idea of like margin before failure, in a sense that to what extent you are allowing like a overlap window. Yes?
It's a description of a treatment, how safe or what is the outcome of treatment in healthcare, let's say.
Description of treatment, okay. So essentially a description of how the model might function and what might be the failure modes. Anyone else? Yes.
I was also like to think that the word ethical is embedded in the context.
Okay. Yes, in a sense, yes. I mean, at the end of the day, the whole idea of like societal and human ethics is to prevent kind of like societal harm. So in a sense, enhance societal safety. So yes. Okay. We have a few ideas here and there, like say for example, like the whole robustness and the factor of safety margin to description of treatments and to the ethical aspect of society. For, let's go with the society bit for a bit, because society fundamentally is a collection of humans, a collection of human agents, let's say, that have come together and decided common protocols of interactions codified by ethics that is designed to essentially prevent harm, and therefore it is designed to kind of like avoid kind of like unsafe incidents in a sense, in a societal scale. So when you talk about agentic AI, if you talk about like an interactive groups of agents, what does safety mean in that context, and what are those failure modes that might inspire the safety conversation in that context, particularly when you are talking about an already risky domain like healthcare. So in that case, if when you ask like why are agentic systems potentially high risk, And the notion is simple, like, like a lot of these systems, particularly when kind of like provenanced on like large scale data and large scale compute and large scale interaction and long range interaction capabilities, you are really talking about essentially this idea that there is a kind of like an equivalent of like perception, reasoning and planning across different clinical workflows. There is kind of like this risk that errors might propagate across time, and essentially it can kind of like blow up in unintended ways or unpredictable like dimensions. And there is always this issue that eventually, because healthcare is essentially a longitudinal domain, there is always the risk of like long term horizon decision chains getting compromised. And therefore, what might be these key failure modes? I mean, this is something that I tried defining myself. I mean, I'm open to interpretation on what these failure modes might be beyond what I have decided here. So in my view, like the first kind of failure mode is a perception failure as regards healthcare. Classic example, hallucinations. Like if I model, if an agentic chatbot hallucinates and gives like wrong advice, which has by the way happened already in some context, leading to fairly adverse outcomes in some context, including like sort of self-harm and suicide. Like what happens like when you have some, for example, like extraction errors, or when you have like issues that kind of compound from particular kinds of context windows and so on and so forth. So these are essentially a failure on the case of the perception of these agentic systems. The next kind is essentially the reasoning failure, like assuming that perception itself happens at a very high context. To what extent is the clinical logic sound, or to what extent is it a consequence of the hallucination that has happened that creates pathways that are plausible but not actually validable, or not actually safe, or not actually free of harm. The other one is this whole idea around action and coordination. What if multiple agents coordinating in a healthcare setting, due to a compromise in a subset of them with regards to hallucination, etc., to what extent is the overall system kind of like risky? And this kind of like I would say in my view compounds even more when you are not talking about a pure agentic system, but more about a human plus agent system, that how do you actually have protocols for handover between agents to humans in a healthcare context. This is something that has not been very well studied or very well codified by law or by the standards of accountability, etc. That what happens in terms of failure modes that emerge due to like handovers between artificial agents and human actors. And the other is essentially a lot of the interaction failures that is tied to it, and other kinds of adaptation failures that can happen when you deploy these systems in the wild. This is a classic continual learning motivation here, that when you talk about adaptation failures, you are talking about things like distribution shift, etc., that compound over time, and to what extent the agent actually maintains fidelity to information that it has seen in the past, and to what extent it might suffer from catastrophic forgetting or similar. So these are some of the failure modes in my view that you have in this kind of a agent healthcare scenario. And as such, what might be the consequences, and how might you model risks and implement safeguards? So one of the things is that when you talk about consequences, like it's it's almost a tautology that the first consequence will be patient level harm, and as a corollary, the consequence will be essentially a decline in trust at the systems level in different kinds of like healthcare systems worldwide. And we have seen examples of this, by the way, not so much in an agentic context, but generally in a digital information context, like during COVID, for example, a lot of the issues around, say, for example, offering information through different chatbots or different social media platforms or different AI generated content created adverse experience for a lot of individuals, which kind of like undermined trust in healthcare systems or healthcare administration systems thereafter, which kind of in a lot of societies caused kind of like a an anathema towards seeking medical care when they should have, or seeking kind of like sort of vaccination and similar kinds of like interventions when it should have been sought. So we have kind of seen examples of this harm at a pre-agentic era already. So this is something that I did see firsthand, because I did work on kind of on a COVID vaccine during my time in AstraZeneca, which was my previous employer, and a lot of the information manuals that were being kind of propagated at an internet scale at the time, there was a lot of AI-based misinformation being carried out. There was kind of like a misinterpretation by AI that was happening at the time, and that kind of has caused in the 5 years since, in my view, in terms of like anecdotal experience, that has caused a lot of people, including in my own family, to never seek medical care because of everything that they heard at the time, and kind of like their anecdotal kind of story of experiences that they heard on some social media or through some AI generated information, etc. So this can only get compounded when you have like agentic systems operating at scale. So then there are other kinds of like issues around kind of like a lot of the risk amplification that happens with like a lot of the objectives and the adversarial inputs that are kind of like are still a very understudied area as regards healthcare applications and their interactions both with like single systems and agentic frameworks and so on and so forth. So obviously, I mean, maybe some of the things that we kind of go forward, and we'll discuss some of these things in more detail, would be around the technical safety frameworks and the governance frameworks that can specifically address, you know, the kind of like the systems that I talk about here, like in terms of the perception and reasoning and what might be kind of like the mitigation strategies. So before we go any further, I think it is important to talk about the data question. In a sense that when you talk about responsible AI, or when you talk about responsible AI for healthcare specifically, and when you talk about all the preliminaries that I talked about, bias, fairness, etc., there is a very fundamental elephant in the room. And essentially the idea that your algorithm and your processes that come thereafter is only as good as the data that you actually feed in for most part, over and above like model level failures and systems level failures. And some of the things I say here, I mean, if you are students of machine learning, you kind of like hear a lot about this all the time without necessarily thinking about healthcare being the use case, is the idea that, you know, at the end of the day, when you're talking about things like healthcare, the data is always very heterogeneous, it's always very fragmented, it's always very, you know, non-standardized. And then there is always this issue that you have kind of obviously this idea that I was talking about, the limited representation bit, and at the same time there is kind of like this emerging discourse on to what extent patient privacy should be kind of like a cornerstone as regards different kind of like emerging algorithmic practices, and to what extent they might be compromisable due to kind of like, say for example, models kind of regurgitating identifiable information and so on and so forth. So in a world where there isn't exactly a uniform standard for data across different scales, but algorithms and their process of building is very much multinational, this creates a new layer of risk where differential privacy standards, I mean not the differential privacy, the technical phrase, but different privacy standards in different parts of the world may very well cause essentially a very different understanding of what it means to actually de-identify patient information and whatnot, and therefore models trained in one part of the world technically might not scale to another parts to comply with regulation or privacy understanding in a different part. So how do you actually have kind of like systems that are respectful of the data realities in different parts of the planet when you are looking into sort of deploying some of these systems? And this once again ties into this whole idea that how do you address the time question along with the data question, because data evolves. In healthcare there is more and more data that emerges over time. Models, we know for a fact that there is kind of like forgetting on data, there is a lot of study on continual learning and kind of like drift around of models when it has not been optimized for all of the historical data, which is simply not possible in healthcare because due to other kinds of legal restrictions, you cannot really store data forever. So you cannot fine tune on all of the data at once ever. So how do you effectively address the question of data drift as regards healthcare, and how do you address the question of data drift at a federated scale across different geographies and across different scenarios, and how does your system kind of reconcile with the legal requirement for provenance and legal requirement for validity over time. So one of the angles of this data question that people have tried to address substantially has been the question of like, you know, addressing the question of sovereignty of data in terms of like particularly healthcare data not being transferable across different systems worldwide. A lot of the effort has been around kind of scaling up federated learning systems. It's a technical solution to a complex social and governance challenge, and therefore it brings with its own challenges like technical solutions usually do. Like when you talk about federated learning, when you talk about things like model merging, or when you talk about things like multi-center deployment or multi-center fine-tuning, eventually that question of the other, you know, aspects of the data conundrum of like, you know, having kind of like differential presence of data or data drifts that materialize differently in different parts of the world, and the very fundamental aspect of defining what kind of like a lot of the data challenges mean or the privacy etc. mean in different contexts effectively means that federated learning as a concept has to go beyond the technical problem. It has to go beyond like technical solutions to doing things like merging models and so on and so forth, and kind of like take into account the local guardrails and the local kind of like accountability mechanisms even when you are fine-tuning models at a global scale. So while I talk a lot about like, you know, in this obviously ChatGPT generated slide, I talk a lot about what the technical interventions might be for federated learning, but keep in mind that this is much more than a pure technical challenge. This is as much a governance and a societal challenge. And close on the heels of that is this whole concept of differential privacy. I've included this here because I want to kind of give a bit of a insight into this technical answer to a complex data challenge of how do you actually ensure individual privacy at scale while kind of respecting kind of like the differing notions of like what it means like on a legal scale to actually have kind of like provenance of data and so on and so forth. Now here I talk a lot about synthetic data generation, etc., and also like multi-party authentication, etc., but it tackles the data question and the risks in three different kind of like frameworks here. Like one is obviously the standard question of to what extent I can guarantee individual privacy at the scale of model training, which is kind of extendable to the scale of how do you actually fine tune for your or design models that are kind of global in scope but have to be trained locally to respect local regulations. So the second aspect is obviously this idea that how do you solve the representation problem, and the third one is the kind of like the data risk and the model risk that might come from the cybersecurity angle, which the third one, by the way, has been quite well adapted in a lot of healthcare systems due to a different kind of a push around, data risk, security risk, and so on and so forth. But I mean, the problem that is on the horizon is kind of like an intersection of those risks along with the data question of like, to what extent is it locally available or locally balanced or so on and so forth. So anyway, so this is where we are today as regards to the data question. So on that same note, I mean, on the note of kind of like agentic safety and so on, I thought I would have a brief kind of 2 slides on the hot topic, the responsible LLMs for healthcare. So when you talk about responsible LLMs, again, a question for the audience. When you talk about responsible in the context of LLMs, what is the first thing that comes to your mind? Anyone?
That if they make a mistake, they are the owners of the consequences.
Okay. Accountability. Anyone else? When you talk about responsibility in the context of LLM uses, like say using ChatGPT for healthcare, for example, what does come to your mind when I talk about responsibility in that context? One answer is accountability. Anything else? So what is important to think about is that when I talk about like sort of a lot of these chat infrastructures, it is vital to understand that hallucinations can actually kill. And therefore, like, you need to kind of have a thinking when you are talking about using these systems or building them, that it's not simply about kind of like a one-off incident or like a kind of like a simple hallucination or passing it off as kind of like a model artifact, but to understand that this is not a UX failure and it's a patient safety event at its core. So in a more analog world, like if we were to think about it in the sense that if a clinician were to kind of like make a similar mistake of kind of like failing to kind of give an information with an adequate source or kind of like failing to answer something in a manner that was clinically tractable, they would very much lose their license or maybe imprisoned or worse. There would be a very severe legal consequence. That is how patient safety failures are dealt with in the analog world. So if you are going to be using LLMs, even as a personal kind of like, say for example, as an assistive tool, in a sense that same mechanism of responsibility should apply. The enforcement is where obviously the challenge would always be. But at the end of the day, this ties into the fact that explainability is actually a clinical right for the subject. It's actually the clinical right for the patient. And therefore, at scale, there is obviously a need for like a significant clinical accountability that needs to be put in. Now, this also means that how do you ensure your LLMs are going to be responsible over an extended time? So that would mean essentially validation over extended time. Once again, we are kind of like repeatedly harping on this point that end of the day, healthcare is a longitudinal topic, and therefore continuous validation and continuous fine-tuning is a requirement, and this obviously has to happen in relation to the data challenges that we discussed earlier. So this is why the accountability question becomes so difficult here, because in a practical world, when you're talking about designing systems at scale, a lot of the legal mechanisms in place that require a lot of this validation almost always kind of can be argued against by, let's say, provider of an LLM saying that such a validation, such an unpredictable validation scope is simply not a feasibility, and therefore there has to be a new class of legislation that allows for essentially continual learning of some of these algorithms and actually regulating them in practice. You do see some examples now, like you have kind of some of the FDA's SAMD guidelines that talk about lifelong learning healthcare algorithms, but in practice, when you talk about large language models or other kinds of self-supervised foundation models in particular, that legislative base may not be fully sufficient, because a lot of the data sets they are trained on are essentially at a starting point in open world data, and the hallucination thereof is not very well understood. But fundamentally, the solution for now is that the human should always stay in the loop. And I think in this regard, it is worth mentioning that the Chinese view in this regard of kind of ensuring that a lot of these disseminated systems and a lot of the social media influencers promoting it need to absolutely have the credentials and the qualifications and systems guardrails for a lot of these commercial LLMs for sensitive topics simply have to be very very exclusive and very robust, that I think is a good stopgap arrangement. So basically using expertise as a guardrail and keeping humans in the loop. So tied to that, obviously in a lot of these technical interventions aspect of how you might ensure responsibility and safety for healthcare agents and other kinds of healthcare AI systems, is that having a more defined red teaming environment that is specific to healthcare. Healthcare AI red teaming has to involve people who have that clinical understanding of and the clinical the knowledge to actually effectively interrogate AI systems and actually use a lot of these group failure analysis that can only emerge when you are talking about bringing multiple specialties together. A lot of modern red teaming takes the form of, say for example, using either an LLM as a judge or using another a human expert at an individual level as a judge and trying to reconcile inter-observer variabilities. But in my view, this is highly inadequate when you are talking about compounding failures of healthcare AI. In a real hospital, once again, a failure is essentially usually a group responsibility, and safety is also a group responsibility. Therefore, how do you actually bring in that cross-functional expertise as regards red teaming is something that a lot of model builders need to figure out. So when you talk about model cards for healthcare, once again, my view is that a model card for a healthcare should be treated with the same level of seriousness as essentially the list of side effect and list of contraindications in a medicine, and therefore a model card needs to be treated with the same level of regulatory scrutiny as essentially something that is describing the risks of existing treatment options and existing therapeutic and medicinal workflows. Today's systems like Petri from Anthropic, etc., they take a view of a fairly generalized system where somehow having seed instructions and simple guardrails and having LLMs as a judge, or having a reward mechanism where a human expert can offset certain kinds of adverse outputs, that may not be adequate for a healthcare systems. So as such, I think it would be, the jury is still out on what might be the best system, but it is important that we have a more multidisciplinary and a more expert focused responsible AI system as regards specifically the auditing aspect of things. So in a way, so far we have talked about a lot of these technical interventions. We have talked about significant aspects around data sources, we have talked about development, we have talked about risks, we have talked about monitoring. So now comes, what is the answer in that regard? I mean, this morning you have heard a lot of this, you have heard a lot about the AI Act, you have heard about the Digital Services Act. I will not go into depth here, but know this in mind that in the EU AI Act and also in similar legislation elsewhere, healthcare applications are treated as a high risk category. So in a way, these are usually level 3 categories, and there is a challenge to that. While it is perfectly feasible to understand healthcare in general being a risky category because of the harm mistakes might cause, but it is also important to understand how to define healthcare adequately in that context, because say for things like understanding your patient populations at scale, or understanding the target biology or disease understanding, etc., that needs to be given a separate treatment as compared to something like dispensing care advice or using decision support or designing clinical trials. And this is a distinction that has yet to be made by any of these legislative frameworks, because healthcare is not a one size fits all an environment as regards clinical systems and so on, or as regards the the legislative risk aspect. So when you talk about risk, I think healthcare does need a more of a delineation on what parts of healthcare are actually high risk and what is more of a research side of things, and more of a, let's say, not necessarily a patient facing or a clinician facing kind of an environment. So as such, the regulatory landscape is promising in the sense that there is a lot of policy guardrails, etc., is coming up, a lot of emphasis on good ML practice, and a lot of self-regulation by the industry. This is one case where a lot of the regulatory bodies and a lot of the healthcare regulators and industry bodies in general have managed to come together to at least kickstart a discussion on at least what a self-imposed set of recommendations do need to be. A lot of this obviously ties into national legislation, and this is one place where a lot of countries have not really kept pace with others, because when you talk about a lot of the regulatory maturity, you see a lot more of that, say for example in Western Europe and in North America, but you do not see an equivalent amount of maturity in other parts of the world, which is problematic from a healthcare perspective, because a lot of the disease burden, a lot of the therapeutic the interventions that have to be made are invariably quite pronounced in some of these regions that are still do not have the regulatory capacity in place to address some of their own unique challenges. despite being kind of like very often the source for data for algorithms and being kind of like the societally more exposed to the harms of AI in healthcare. So at the end of the day, when you talk about AI in healthcare, there are clear societal dimensions. There is a whole range of issues ranging from equity to kind of like clinical education and so on and so forth. I absolutely haven't touched on the education bit at all, like the fact that there is a lot of evidence today that increasing use of like particularly chat-based infrastructure in healthcare, etc., is causing a lot of decline in clinical skills. There has been a retrospective study already that has been published that talks about clinicians increasingly being reliant on these algorithms almost as a matter of practice, and therefore losing some of their expertise and ability because of this reliance, similar to how a lot of us are losing the ability to write a LinkedIn post without using ChatGPT. So with this, before I move on to the drug discovery part, a lot of you obviously will have a great future as entrepreneurs and will be building the health AI systems of tomorrow. These are some of the 5 things that I want you guys to keep in mind. So you need to validate the problem. Yeah.
Maybe before you go to the next topic, can you mention a couple of examples where AI is actually already being used?
Yes, I can. The reason I was not mentioning is because as an employee of a pharma company, I do not want to use proper nouns. But okay, so there has been a lot of actually FDA approvals when it comes to this. There has been, I think, at least 3,710 kind of like software as a medical device approvals by the FDA that concern some level of artificial intelligence usage. Now there is a catch here, is that a lot of the AI usage here can be very simple linear regressions, etc., and companies talked about using AI so that they could increase their valuations and so on. That is also a thing that happens. But generally, there has been quite a few FDA cleared examples of kind of like medical devices that essentially use AI. Say for example, a lot of your radiology hardware today, a lot of the kind of like the segmentation, the auto segmentation suggestions it gives to the clinicians, that would be an example. A lot of high-end scanners, for example, in sonography, the fetal biometry measurements that a clinician is presented the moment a scan is taken, a lot of the standard plane discovery, etc., those would be examples. For example, all of the butterfly network systems of ultrasound plug and play on mobile devices, that is an example that is very much in the field in emergency medicine and in low resource critical care. Then a lot of the prognostic decision support and EHR understanding. So during COVID, not so much in the UK or Europe, but in China, there was a lot of usage of systems from Tencent and Alibaba, from what we know, that were being used to quantify or triaging patients, like particularly quantifying ground glass opacity and so on and so forth in lung volumes. Then a lot of examples come from, like, say, in low resource deployments and kind of like things like, say, for example, proactive disease surveillance and proactive kind of monitoring of, like, say, emergent pathogens, etc. So these are kind of some deployment examples I can talk about on top of my head. There are a lot of these examples where a lot of bias issues happened. For example, a lot of the skin cancer and skin imaging diagnostics that did get exposed because of the obvious bias issue there. There have been also, like, some of these examples of spectacular failures when it comes to clinical trials or trials of AI algorithms. Classic one being Google's AI diabetic retinopathy scanner that led to, I mean, it was kind of like an interesting one because the algorithm was so well validated in curated data, but the moment people started actually trying this in a clinical admissions workflow, the failure modes were just compounded. I mean, this is not even something where a bias would normally happen or a fairness would happen because you're talking about retinal scanning. But the very fact of, like, the fact that the diversity of the training data did not reflect the diversity that you saw in the wild, that kind of was essentially a result of a lot of the catastrophic failure of that algorithm in practice. And they did a trial in India. So that was also, I'm not sure why they chose Indian hospitals for this trial, because this is one of the most challenging demographics that you can do clinical trials on, and also the most interesting ones, obviously, because of the huge variation in the population pool. So if you had one location where your data validation would require a significant amount of actual training diversity, it was that country, it was that kind of like a healthcare system. So maybe they were very confident about it at the time, but this is one of those very classic failure modes and very classic lessons in why it is important to consider, like, your training data being kind of like representative, one, and two, having like a continuous validation and a continual learning kind of like an approach as the default when it regards healthcare and its biases and harms. So with these lessons here, like, you need to validate the problem and not the tech, and most importantly, you need to build for the world and everything else in between, like talking to clinicians and designing and building for trust from day one and preparing for messy data. I hope I have given you some food for thought here. So So if you are entrepreneurs of tomorrow, always keep these things in mind. They might sound boring and not the very cutting edge thing, but this is crucially important for success in the real world as regards healthcare AI. With this, let's go into responsible AI specifically for drug development. Okay. I'm a bit tired, so I need a drink. What time is it?
It's 5 o'clock, so you have to find one.
We have half an hour, okay. 5:05.
Maybe quickly on the diabetic retinopathy imaging, it's really difficult to report properly. So it's not just that the algorithm failed, it's the quality of the images is really poor, and it's really tricky to get quality images without strategy.
Yeah, I mean, yeah, that's always an issue, right? I mean, and this is a classic issue that I talked about in the data problem. And when I say this message that built for the world, is I realize that the data quality can vary in different parts of the world. The acquisition realities can vary in different parts of the world. And basic things like availability of power, etc., can vary in different parts of the world, and these can shape local priorities. So last year, I was in the deep learning Indaba. I was speaking at a panel in Kigali. And so the deep learning Indaba is one of the foremost AI events in Africa. And we had this panel discussion on what might, say for example, like clinical workflows around AI in the global south learn from the global north. And a lot of the panelists mentioned, like the global north tries to teach us a lot, but our classroom is very different. And that is revealing in the sense that when you talk about a lot of them, you had actual clinicians there. For them, the operational reality is that the first thing they worry about is that if you are a pathologist or radiologist, you do not have regular electricity all times a day. So that means that your patient load is highly magnified in times when you do. So the time per patient is significantly different from, let's say, a standardized critical care hospital in the global north. The second is that the expertise availability is significantly lower, and therefore like the same staffers and the compounders are kind of distributed across multiple sites. And the third is that the interpretive capacity is heavily reliant on a very small window of like clinician time, and therefore the number of misdiagnoses or the kinds of things to prioritize, that is significantly different from what is elsewhere. So in a sense, like the world operates very differently as regards to the deployment of AI in different parts of the world. And that is, I think, important to understand. At the end of the day, the things may come from, or the issues may come from things that you least expected. And how do you build robustness as a design principle around these, as opposed to an afterthought? Anyway, so moving on to the next part, responsible AI in drug development. So I told you that I work in pharma. I do a lot of work in kind of around generally different stages of drug development. I work a lot on building AI for non-clinical safety evaluations, some on AI for clinical trials, and some on early discovery and designing molecules. When you talk about responsible AI and risk and kind of like safety, etc., it goes in all kinds of directions, ranging from somebody hacking into a molecular design engine and using it to design chemical weapons to things that are more basic like bias in clinical trials. And as such, it's a huge world that I simply cannot cover in the next 10 slides. So I'll just skim through them, and if you have specific questions about some of them, then we can talk about, in between or after. So before we go into it, this is what drug discovery looks like in a nutshell. Very large time windows, 10 to 15 years, very large costs, upwards of like 10-20 billion or so. Roughly, you would look into 4 different phases when you think about it from a commercial pharma landscape. You think about early discovery, you think about preclinical, then you think about clinical, and then think about what is known as like post-market surveillance, which is the enduring pharmacovigilance of like, kind of medicines once they're out in the market. In early discovery, like, you have things like target identification and lead generation and molecular design and so on and so forth. When you hear a lot of the AI for drug discovery, a disproportionate amount of focus has been on early discovery, designing new molecules or understanding targets, etc. But it is the stages that happen after it is where a lot of the promising molecules actually go, find their graveyard, when a lot of the toxicity and the efficacy guarantees are simply not met, and a lot of the animal model data ends up being inconclusive, and eventually things cannot advance into clinical trials. And even when they do, the clinical trial throws out all kinds of messy realities, which overall means that it's about 1 in 1,000 candidate that roughly goes into the, the medicine cabinet eventually. So it's a very high risk, high reward industry. And a lot of the premium essentially is not so much the success of a particular molecule, but in actually failing early. So that is, I think, a lot of the very unique aspect of this industry, that defines how you see a lot of these things play out in practice. So yeah, this is what it looks like. I want to give a moment for you guys to absorb it. And with this in mind, let's talk about responsible AI for pharma. So when you look at this life cycle, and it is important to think about what might be some of the key integration points of AI in the first place. Now, as a catch-all statement, I could say that AI is revolutionizing pharma, etc., and whatnot. But the revolution has very specific biases in terms of what parts is most touched by it. And chief among them is actually target ID and molecular design and kind of like decision support kind of aspects in clinical trials. So there is a huge market value here and a lot of aspiration for reducing cycle times and so on and so forth. And this is also where a lot of the accountability gaps and the risks actually come in. So this idea of if you start here, like the idea of like generative AI for molecular design, by far the sexiest topic in the AI for drug discovery industry. You had a lot of excitement in the last 5-10 years, a lot of funding going into this space, and increasingly a lot of like questions being asked about like to what extent the promise has actually been met and to what extent it is not. So while a lot of the technical stack has quite well established as regards building molecules with different properties, there is kind of like a fundamental issue here that the model fundamentally does not understand chemistry, it is replicating patterns. Now once again it is learning these patterns, and therefore the model does not have an innate ability to enforce guardrails of safety for most part. So for example, there was this very famous MIT Tech Review article about somebody actually hacking one of these generative engines and using it to design kind of like chemical weapon molecules, etc., and came up with more chemical weapons in an afternoon than in the last 70 years of human history. And that same algorithm was actually designed for essentially drug discovery. Even if there were guardrails in place that would kind of like try and prevent kind of like maybe this kind of an incident, there is no conceivable way in which a guardrail can be exhaustive enough that would allow an algorithm to differentiate a molecule from being a medication to being a chemical weapons agent. Because at the end of the day, that requires a fundamental understanding of chemistry, which most of these models, to our knowledge, simply don't have. There is a lot of talk about emergent behavior here. There is a lot of talk about using kind of like longer context windows, etc., to understand chemical knowledge. But given that a lot of like, molecular structures with very minor modifications can end up being kind of like something that is insanely toxic, sometimes medications have kind of like they're kind of like different isomers that end up being toxic. Classic example being thalidomide. The dextrothalidomide is a medicine, L-thalidomide is a toxin. So this is kind of like the level of context we are really talking about, and therefore all of these algorithms do carry an element of existential risk and an element of like making a case for like strong guardrails of deployment, because they don't understand chemistry fundamentally. And with that, today you see a lot of agentic AI in drug development and drug repurposing. So you do see, for example, a lot of like different kinds of agents that are used to inform the target discovery and the disease understanding landscape. And a lot of the promise there is that you want to make the timeline more efficient. Like a lot of the work that human chemists and knowledge providers would historically do, things like going through databases like Campbell or NIH and so on and so forth, and doing large scale literature surveys, or doing things like generating multiple hypotheses, or generating things like potential lead candidates, or generating things like sort of like evaluations of like sort of failure modes in terms of toxicity or efficacy and so on and so forth. All of these cases historically have had been done by specialized teams of like chemists or scientists or scientific information bodies and so on and so forth. With increasing emergence of like agentic workflows taking over, and in fact like me and my colleagues, we did a survey on this. There is a paper out in drug discovery today called Agentic AI in Drug Discovery, where we actually discussed some of these failure modes in detail. It is important to understand that if you do have a network of agents, for example, hallucinating on the literature side of things, those errors are going to compound like sort of quadratically, because a hallucination in one part of the pipeline means that the rest of the pipeline also gets compromised and kind of carries the effects of that hallucinations for most part. This is kind of similar to the longitudinal aspect in care delivery, but it's also different in the sense that when you are talking about using literature understanding to come up with hypothesis generation and molecular design, you kind of might end up like missing kind of like the subtle gaps in between the therapeutic efficacy versus safety versus toxicity, that paradigm. So essentially those boundaries are very easy to cross with even the slightest of errors at a very fundamental stage in literature discovery, for example. And this is where a lot of the accountability mechanisms need to be in place, because if you have a group of agents at different parts of the pipeline, the accountability just gets diffused. There is no easy way of checking that where exactly the failure mode was, and therefore what might be the interventions is something that we need to think about. Now, today's pharma companies, while there is a lot of work being done in terms of integrating agents, the responsible AI aspect is still a very nascent conversation. It's still at its infancy. A lot of these failure modes are increasingly becoming kind of like accepted and appreciated. But so far the solution has been a mixture of essentially human in the loop and trying to use legal mechanisms of responsibility and assigning it to vendors. And a funny consequence of that is that a lot of companies have decided to just use external vendors for a lot of these agentic workflows, because then it becomes easier to assign the blame in a potential legal challenge. But that is something that is a very much a stopgap arrangement, if you ask me. And there is a need for like a lot more sandboxing and a lot more kind of like a enablement of human checkpoints at different parts of the workflow. And the key technical and pharmaceutical and an agentic AI challenge here is that how do we actually establish these checkpoints for this specific domain, and how do you actually scale it to different aspects of drug discovery? This is a technical and a kind of like an industrial question that doesn't have very good answers yet. How do you accurately identify human checkpoints of intervention in a pharmaceutical workflow that is increasingly going agentic? So I could go on and on about it. I could touch upon different aspects of it, but in the interest of time, let's actually just get into AI in clinical trials. Again, clinical trials. So in the audience, when I say the word clinical trial, what comes to your mind? Everyone has heard something or the other about clinical trials. I just want to hear what is it that you have heard about clinical trials, and what do you think of clinical trials when you hear it? Anyone? Clinical trials. It's a thing, okay. It's a pain, okay. Okay. Anyone? Yeah. Testing a new drug, yeah. So, a clinical trial, yeah. So there is a particular phase in drug discovery called preclinical testing, which is where testing happens on animal models, and before that on in vitro like assay systems, to look for whether a molecule is efficacious, safe, and or whether there are unexplained toxicity effects, etc. In this, what happens is that you actually test a drug on animals and see if, like usually rodent models, but sometimes dogs and monkeys as well. There is kind of like this whole thing about like to what extent is there a physiological change in function, and then you sacrifice the animal and then you look for tissue level changes. And you use kind of like 5 organs for that, like liver, kidney, spleen, bone marrow, and kind of sometimes the brain. And you essentially look for like sort of signs of kind of like say necrosis or vacuolation and similar kinds of effects. So this is something that happens as a standard practice, and there is a lot of push to digitize this. I mean, I work a lot on kind of ending animal testing and kind of having digital models to do this predictively much better. But subject to the results of this animal testing, a regulator approves some medicines clinical trial application. It's called a CTA. A CTA comes with different kinds of components, like you kind of like choose what are known as trial sites, you select trial sites, you select patient cohorts, you kind of identify what kind of like patient groups will be kind of chosen for a trial, who will be the control groups. And there are kind of like regulators in different countries, like for Europe it is the EMA, for the UK it is the MHRA, for the US it is the FDA, and so on and so forth, who kind of greenlight the start of a clinical trial. Clinical trials happen in roughly in 4 phases. Phase 0, which is kind of like the initial, like the planning. Phase 1, which is where you kind of do like the very initial proof of concept validation on healthy subjects. Phase 2, 2A and 2B actually, which is where you refine the dose and you look for signs of like adverse harm. And then phase 3, which is a much more demographically expanded kind of like a validation of the therapy concept, validation of potential contraindication, validation of potential harm. And then this is followed by kind of like a authorization application, which is then followed by an enduring pharmacovigilance or enduring post-market surveillance. Now, a lot of the promise of artificial intelligence, and by the way, like the clinical trial design was one of those aspects of like, you know, pharmaceutical innovation that was a very early designer of a lot of systems that inform today's AI. For a lot of the causal inference literature, a lot of the literature around, for example, kind of like talking about treatment effects, a lot of the literature around randomized control trials and so on and so forth, which we heard in a previous speaker. The clinical trial industry was one of the kind of like the pioneers of a lot of these innovations. And therefore, it is natural that today a lot of people are talking about, you know, asking what kind of like artificial intelligence and LLM-based systems or agentic systems can help refine the process. because clinical trials are costly and there is a lot of failure that happens at this stage. So there is for example, when you talk about things like site selection, as in wherein will you do a clinical trial, or you think about identifying which patient groups are actually your subjects and which patient groups will be your virtual control groups, or so on and so forth, and how do you actually kind of like do the selection and the monitoring of a trial. Each of these things have increasingly see the use of some of these algorithms, and a lot of the things that are fairly basic today, like protocol generation, etc., which involves like producing a lot of information, are increasingly seeing LLM adaptation, and therefore there is that standard LLM risks that apply here. And also like the increasing like the question of like to what extent like the data question can be solved for different patient groups who have been underrepresented, are seeing the usage of synthetic patient data generators. So the standard risks of like misrepresentation and hallucination are very prominent in this one case, and this is something where regulatory acceptance is fairly jurisdiction dependent, to what extent like you can use like simulated arms and so on and so forth. So this is where a lot of the discourse is still evolving, like to what extent you assign the accountability in case there are hallucinations in a, let's say, in a digital twin that you use as a virtual control group, and what might be the derivative failures that might result. But that said, I have seen very unique examples of people trying to do kind of like use algorithms, and some of that sounds funny, but I once, for example, reviewed a paper that talked about monitoring what is known as trial adherence using a mobile smartphone camera. So the medication was a pill, and they wanted to ensure that the patients who have enrolled in a trial have actually taken the pill every day or not. And their idea was this AI agent that actually reminds the patient on their mobile, and they take a selfie of taking the pill, record the video, and the agent validates whether the pill was taken correctly or not. So some of these applications in terms of clinical trial adherence, I mean, that's, I think, going to be kind of like a gold mine for a lot of these maybe regulatory issues and a lot of the kind of like the bias aspects eventually, because of the kind of like the failure modes that might compound if you do not kind of accurately validate those. Now, to what extent a software like the one that I just described, or to what extent a chatbot that is used to understand whether a patient is a good fit for a clinical trial cohort or not, to what extent can that be treated as a medical device, is not very well established in a lot of jurisdictions, because this is not something that offers a diagnostic kind of like a information that is purely used by essentially a trial organizer or an intermediate company to do the basic selection. So the current kind of like the consensus in the community is that use these things, but always have like a human sign off on the final kind of like the trial selection and the clinical trial authorization, like the document. And this is how kind of responsibility is currently assigned. But as these things scale, it is important that we come up with better mechanisms of accountability, and we come up with better kind of like guardrails against issues like bias amplification or overfitting inefficacy, or making kind of like a lot more of a adaptive decision without adequate interpretability and so on and so forth. And one of the core worries here, and this is something that is anyway a worry in clinical trials, is this whole idea of like population scale generalization of particular medicines. This has always been an issue even with like purely human run trials, simply because of the inability to do site selection in a sufficiently representative manner, and with kind of like AI algorithms kind of promising to offset that with synthetic data. This is kind of something that is yet to be studied, and to what extent can they be incorporated in adaptive trial design is something that is where a lot of the research questions for AI for clinical trials will be shaped in this decade. So before I conclude, I want to give a bit of an insight about this shiny new thing called self-driving labs. There is a lot of like discussion about the labs of the future being entirely robotic, and there is this whole vision that is painted that you will give a prompt in your mobile app of a some kind of a chat interface, and you will describe that, make me a medicine for I don't know, maybe like pancreatic cancer or something, and then the agent will kind of like go through literature. All of these agents will design their own molecules, and this would be tied to like a warehouse with robotic arms, etc., and they will do the synthesis of the molecules, and then eventually they will package it and send it back to you. This is kind of the vision that is grandly painted, and some of the subcomponents are in place, like self-driving labs as regards like robotic automation of running large-scale assays. That is still a thing. That is something that does exist today. There are vendors like Arcturus who provide this solution as a service, and for now the application has mostly been that you kind of like provide experimental protocols that are fairly repeatable and generalizable, and the robotic assembly kind of gives you back the results in a dashboard, and kind of like it allows you to essentially do batch processing of assays and so on and so forth. A scaled up version of this self-driving labs kind of has this vision of making some of these labs autonomous, in the sense that they can do like advanced what if scenario analysis and can actually come up with their own assay ideas of what kind of like decisions to take and what kind of experiments to further run. And therefore, there is kind of like a very strong chance in a future date of some of these systems kind of compounding to unexpected like trajectories and unexpected failures and leading to a complete breakdown in kind of like the operational environment and causing essentially a catastrophic risk potentially of leaking out harmful pathogens or harmful chemical agents into the environment. We have had these incidents even in a human-driven system, like you had Chernobyl that famously happened due to essentially a lack of accountability in the rank and file of the scenario. Such a scenario, when it regards something like a self-driving lab or a mixture of hardware agents, is very much feasible without having adequate human oversight or guardrails in place or having kind of like that task mapping being absolutely robust. So this is something that I do see being kind of like a concern in a summary school here 10 years down the line. So maybe you'll have like then somebody will come and talk about self-driving lab responsible AI and have like 50 slides on it, because this is certainly getting a lot of attention today. And the other aspect like is something I talked about earlier called pharmacovigilance. Pharmacovigilance is this eternal monitoring of like medicines that happens both in the safety stages when a drug is being tested in animal models to clinical trials, and fundamentally it doesn't stop, a company or a regulator doesn't stop monitoring a medication once an authorization is given. Monitoring of effects of a medication or a population scale and contraindication is essentially a lifelong journey, and that happens all through the life of that medication. And increasingly the risk here is that the AI specific, responsible AI specific risk in pharmacovigilance today is that a lot of the monitoring happens essentially from patient reported data on social media and other kinds of like, kind of non-standard sources and not just clinician reported data, which has this kind of like this unique potential of getting kind of a compounded biased feedback or a geographically biased feedback as regards the efficacy or contraindication effects of particular molecules, as there is the risk of like misinformation kind of making the data availability to regulators in a pharmacovigilance setting more spurious. And therefore there needs to be kind of like stronger oversight mechanisms when you are using some of these tools for understanding the pharmacovigilance landscape for a particular medicine. I'm happy to discuss this in detail later, but right now in the interest of time I'll just move and conclude the presentation. So you have something known as the WHO Smart PV guidelines, just for information in the slides I mentioned it here, which kind of talks about these risks, including like the clinical trial risks and the safety monitoring risks of like a lot of these agents in practice, and is quite robust in my view and quite a good reading material. And also talks about this, kind of the need for AI alignment in regulatory submissions. Actually, when you file for clinical trials, there is this absolute need for regulators to enforce some of these mechanisms in practice and have a lot more of a requirement increasingly for model cards, etc., insofar as AI-enabled devices or hardware or software is used for clinical trial selection or for other aspects of the drug discovery pipeline. So with this, I think we do have come to the end of the session, and it's already 5:30. And everyone, today we have had a lot of discussion about this whole idea that benchmarking being kind of rigged in a lot of cases, and a lot of the incidents of like benchmarking having become the target itself, as Emilia was talking about. This is a huge challenge that you actually have in healthcare AI. A lot of the benchmarking is simply not reflective of clinical reality. A lot of the benchmarking is increasingly not in a state where it should be. So the question is, what is it that you should do? How do you actually address the continual nature of healthcare AI and have benchmarks that reflect it? And how does it become geographically and overall more kind of representative? So when you talk about metrics falling short, or when you talk about what we need, I think the core thing to keep in mind is that at the end of the day, your outcomes have to be patient-centered. At the end of the day, trust is something that is non-negotiable, and therefore there is a need to actually have like kind of like a policy cycle design for a lot of these interventions. And there is a need to kind of have essentially a good amount of choice on the regulation versus tooling kind of like the mix, and then eventually kind of like bridge the gap between both health policy and healthcare ready delivery. So with that, I will basically skip the assurance section in the interest of time. So thank you everyone for this. What is the time there now?
It's 25 past 5.
Okay, so we have 5 minutes.
5 minutes.
Or we have 10 minutes.
10 minutes.
Okay. Ask any questions, any discussions, and there are 5 slides around AI assurance. I will just briefly mention this. The reason I have AI assurance here is that this phrase has become very popular now, but it's fairly new. So assurance for healthcare algorithms is still being defined. So I just want to put in your minds that there is this line of thinking as well. But before that, any questions, any comments, any discussions, any burning kind of like ideas?
comment or question in the previous part?
What will have the bigger effect on drug discovery, the automated labs or the AI in drug discovery, like the synthesis routes?
I think eventually it would be a mixture of both. Like the vision, essentially, the aspirational vision is that you have AI for synthesis followed by self-driven labs, so that the synthesis can actually be replicated in the hard and the formulation form. But in the short term, I believe it would be the synthesis aspect. Insofar as synthesis is able to kind of capture effects of toxicity and longitudinal downstream effects, and is able to be sufficiently predictive of animal model failures. So every single drug discovery outfit, say players like Isomorphic, etc., if you ask them what is their primary pain point, it's very often that what the algorithm designs or is even like trained on by incorporating data from like longer range information like ADMET predictions or things like DMPK characteristics that have been reported for in vitro data, nothing just scales to animal models. So there is always that issue that you never really know to what extent your algorithm actually was predictive enough of a molecule, because look, molecular design is not a very hard problem. Today, you can design molecules in your laptop, you can design a lot of the using kind of like, say for example, any of these commercially available kind of tools, etc. So that part has been fairly, commoditized. The problem is that when you talk about designing the right molecule, how do you ensure that it is right for an animal model, it's right for a human trial, it's right for a large scale kind of a population level like a human delivery. And a lot of the issue there is that, a lot of the success when you hear about, say for example, in silico recursion, etc., promising clinical trial candidates, well, it is very much possible that if you generate thousands of molecules, one of them might stick. So if you have kind of like it entirely digital, and eventually you kind of use your digital results, and you go into an assay-based testing, you do not really know a priori that how that result might be, and this is where a lot of the unpredictability comes in for AI in drug discovery. So it ends up becoming, as a result, a question of hype cycles, a question of money, and a question of being able to iterate very rapidly. And in a sense, this aspect of it does not make it very different from big pharma, does not make it very different from what traditional pharma does, except that the molecular design part becomes a lot more efficient. And till so far, we are able to kind of have it more predictive in a more downstream scale without overfitting or without having like spurious correlations. We are kind of staring at a bottleneck. Okay, let's talk a bit about assurance. So AI assurance is essentially this new line of thinking that when you are using artificial intelligence algorithms in practice in the wild at a population scale, it is important to have assurance in the same scale as you have, say for example, life assurance or kind of like assurance of risk or assurance of like, sort of tractability. So it's the idea that for hardware products, let's say your washing machines or your cars, etc., there is a very significant margin for safety, and there is a very significant need for very strong descriptors of adverse events and very strong descriptors of failure modes, and what are the optimal design considerations. So the idea is to extend that same level of scrutiny and that same level of reporting obligations and same levels of factors of safety to artificial intelligence agents. So essentially the key assurance objectives are that you need to have robust frameworks for governance, you need to have robust frameworks for fairness, safety, ethics, etc., all of the preliminaries we talked about, and you need to kind of have, most importantly, a very strong sense of a validated reliability. So when I use the word reliability here, I do not mean the English meaning of reliability, I mean very much the mechanical engineering meaning of reliability. There is about 100 years of literature and research on safety engineering and reliability engineering, which you learn when you are doing, say for example, courses like aerospace engineering, etc. There's a very mathematical domain where you actually define product reliability and a safety landscape. You have this whole idea of like having DMTA cycles and like concepts like Six Sigma and kind of like design for manufacturing, design for quality, etc. This is a whole world in itself where you define the reliability and the systems warranty for a hardware product. And the question here is that this applies very much to performance and failure modes and safety at the same time, and is a cornerstone of the assurance discussion, is that how do you actually kind of like get into the point of where AI algorithms can actually get to that point where I'm able to have like a mathematical reliability configuration and a warranty function to define some of the assurance aspects. And also there is obviously the cybersec aspect that is very much like tangential to a lot of these different aspects. So when I talk about assurance in healthcare, it has to be multimodal as a default. So if I have to understand multimodal AI assurance, like it's almost always the same issues that come in, but what is the assurance mechanism is where a lot of these discussions come in. And I think a lot of these are very straightforward in a lot of the healthcare discourse already, given the risks we have seen in terms of patient harm. This whole idea that you need like pre-deployment authorization similar to like a preclinical trial, and you need post-release auditing like a post-market surveillance for pharma products is very much analogous to a lot of these aspects. The third-party assessment aspect essentially talks about this whole idea of having independent regulatory mechanisms for AI, and there is kind of like an end case of that is having something like a IAEA for AI applications, etc., at a global scale. So how do you actually create governance mechanisms that actually does assurance at scale? Now, today there is a lot of discussion up in the air at both technical scales and global governance and multilateral diplomacy and similar kind of domains, is that how do you operationalize such assurance in practice, and how do you bridge the technical, the social, and the political realities of assurance. And as such, there is a lot of like, pillars in which assurance can actually work, ranging from governance and infrastructure to things like operational and actually practice spaces. So essentially a lot of this today relies on self-regulation and relying on regulatory frameworks that are still emerging, but there is a lot of kind of like a room to explore on how assurance might look like in practice, particularly for critical domains like healthcare, in very different scales like local, national, and international. Note that when I talk about assurance in this manner, it's a bit different from your standard legislative and governance discussion, because we are really talking about kind of like validating performance and validating reliability at the scale of the individual user. So we are really talking about a lot of an intersection between like self-rating of like particular algorithms, etc., to kind of like regulatory mechanisms that enforce it. So I'm thinking of artificial intelligence in this case as your standard appliances like your car or a bicycle, etc., which simply cannot really fail with all the knowledge you have and with all the guarantees that are given by manufacturers, etc. And if they do fail, there is a fair amount of like a penalty that is imposed, and there is a fair amount of like safeguards that are already placed. So can we get to that point for AI applications in healthcare? That is, I think, the million-dollar question here. And while you do have an emerging technical stack and you have an emerging network of like observability and monitoring systems, I believe like a lot of the discussion that is happening in that different scales will still need to emerge, and a lot of the safety institutes worldwide are carrying this discussion, including for healthcare. And I think this is one of those domains where a lot of the research and a lot of the practical operational realities will eventually shape the healthcare AI adoption debate in the next few decades or so to come. So with this, I want to thank you all for your attention. I understand this was an afternoon session. I hope I was not too boring, but thank you everyone for staying awake.
It is a very interesting talk. You are observing different aspects about the regulation, responsibility. Assurance is fundamental. Yes. Please, do you have a question about the different topics? Really, it's fantastic. I enjoyed.
Yeah.
And I, particularly the lax area, assurance, is fundamental, because really the next step that we must pay a lot of attention when we deploy the AI system. Unfortunately, Arijit, today will be in the show, you will attend, but yes, tomorrow yes, he has the flight to go back. Yeah. Will not be here, but they can contact with you for any question in the future. They are working in you are working in the student project, and the AI assurance is also an important aspect to pick up attention. And tomorrow you have two sessions as two student work sections. One session we will have one session at 11:30, because the Luis Seco will be at 2 o'clock in order to have two different student sections separated. One in the morning, Juanlu is one student section at 11:30 tomorrow, another one in the afternoon. We will maintain Luis Seco at 2 o'clock. Initially we announced Luis Seco at 11:30, but it's better to have two session students. One at 11:30, please ask to Nuria to check and to work together with the student teams, and a second section in the afternoon. Well, any question?
Yeah, so look, I mean, this was 50 slides. It was a bit of a sprint. I can talk about each of those topics in a lot more detail. I mean, I can do 100 slides on each of the topics, but obviously we don't have the time for it. So if you want to know more about any particular area, please ask. I will do my best to succinctly describe, something about drug discovery, about clinical trials, about healthcare, etc., any of it. And obviously here is Avicenna's quote talking really about AI assurance and causal inference. This is from the 11th century. So, AI assurance is very much a human reality. It's very fundamental.
It's fundamental. Yep. Okay, thank you very much.
Thank you.